Welcome back to KBC News Check. On this second hour, we'll be looking at matters epilepsy, and to be specific, we'll be looking at how we can improve epilepsy awareness and access to care in Africa. Because to be very honest, we are staring at a crisis, invincible crisis that is within us, within millions of homes in Kenya. But one of the reasons is because epilepsy still is being treated as matters witchcraft, or something that has been done to your kid or to a family member. That is what we want to demystify. And how do we improve access to epilepsy care, and especially when it comes to, now we are talking about Vision 2060, not even 2030. This is what we will be looking at on the second hour. And because of the interest of time, allow me to rope in my panel of experts, beginning from my immediate left, where we have Dr. Phyllis Kimani. Dr. Kimani is a leading pharmacist, passionate epilepsy advocate, and a powerhouse behind NeuroReach Africa, dedicating her career to drug access and also public awareness. That is why we are having this conversation. Just next to her, we have Nicholas Otieno, an expert clinical epileptologist from the Kenya Association for the Welfare of People with Epilepsy, or KAWE, and also matters diagnosis, treating, and building community-level systems. Karibuni. Perhaps to start with you, Daktari, growing up, before I understood this, and I also had my time in the medical field, epilepsy is still being taken as something happened, or maybe uchawi, some witchcraft or something. Yeah. Could we try and demystify this?
Yes, thank you very much for having us.
Welcome.
This is a conversation that is well overdue. Mm-hmm. The reason is, as you're saying rightly, growing up, we have grown up knowing that epilepsy is this condition to be feared. It has a lot of stigma, and these stories started when we were very young. So there were theories about it's contagious, it's witchcraft, it's a mental illness, and these are things that we inherited from our churches, from our communities, and the only way to change this narrative is to go back to right from the start, right from the children. Let's teach them a new narrative about the condition. Because as you're saying, all these are myths. And the truth is, epilepsy is a medical condition of the brain, and it is treatable. So there's a lot that needs to be done with regards to the right information getting to everyone at large.
Yeah. Nick, building from where Doc has left in regards to even, diagnosis. Maybe in Nairobi and big towns, maybe we have a number of medical experts in the field, but let's look at rural Kenya. How bad is the situation in regards to not only awareness, the treatment as well?
Yeah, basically there's a challenge from the awareness aspect. People are not aware of epilepsy as a medical condition. The second part is that even the medical team are not well equipped on how to diagnose epilepsy. When you mention about epilepsy anywhere right now, what will come to someone's mind is a consultant. And the consultants in rural areas are hard to come by. Yeah. So the first thing will be, where is the transport to where this consultant is? The second question will be, where is the consultation fee for this? So basically we are looking at making sure that epilepsy is managed at the primary healthcare level, so that even in the rural areas people can access the epilepsy management as they require, because it's their right. This belief that you can only manage epilepsy on other levels is making it difficult for even people at the rural areas to access medication and treatment.
Yeah. Yeah. Doc, you started NeuroReach Africa.
Yes.
What exactly are you doing in matters awareness? And just like Otieno has pointed out, when it comes to rural areas, awareness and treatment becomes the biggest issue.
Yeah. So NeuroReach is a non-profit organization, and we look to improve the lives of families affected by epilepsy, and we do this through three things. The first is research. So we are advancing research into epilepsy, including more novel treatment options. So these are for the epilepsies that are more difficult to treat. We're doing a lot in innovation. So we're looking at digital solutions that are in the reach of Kenyans, regardless of where you live. So we're looking at, for instance, on our mobile phones, there's a lot that we can do because Kenya has a mobile phone penetration of about 125%. So a lot of people have phones in their pockets. So we're trying to develop tools that can help these families via their mobile phones. And finally, through community impact. So we have written what is called the NeuroRich Friends series, and these are books that are targeted to children from as young as 4 years old up to 10 years, because that is where we have realized stigma begins. So why not target it before it actually starts? So very simple storytelling, we are able to demystify this illness and break the thousands of years of misinformation that we have through telling stories.
Of course, we will be looking at the books as well, and
Yes.
you'll be telling us what exactly necessitated you to do this, because I believe this is one of the best things that you can do in regards to a condition that is not well understood in the country. Nick, I'm looking at how we can bridge the massive shortage of specialists and also caregivers. In as much as we would want many Kenyans to study maybe anything, any medical field that touches on epilepsy and its care, how can we train the ordinary clinical officers, and also we have the CHPs now? Is there a way that we can maybe train them to maybe not only demystify the condition, but also be able to help, especially they are able to get deep inside the rural areas?
Yes, so basically as KAWE, we have our model of how we approach the community on epilepsy management. We do community awareness sessions where we talk to the community members on what epilepsy is, and we demystify the myths and the misconceptions. In these sittings, we have the leaders within the community, the gatekeepers basically, the Nyumba Kumi initiative, the chiefs. They are all put in a set. We have a conversation about what they believe epilepsy is. Then we guide them on the truth about epilepsy. Then from there, we have training sessions for community health workers. We do it county per county. We have community health workers are brought. They are trained on how to identify persons with epilepsy within the community, and they channel them to the health facilities. So we have a set of training sessions that we do to community health promoters. Then we have what we call the continuous medical education for primary health care providers within a county that we go to. So after doing that CME, they are trained. After being trained on how to manage epilepsy, the trainings also give them CPD points for renewal of their licenses. So it gives them something to look forward to when they are attending these trainings, and they're also equipped to manage the epilepsy condition within the facilities they are in, so that we reduce the accessibility challenge that we are having at the moment. So we have that program on how we train them and we create awareness.
Doc, back to the basics, the diagnosis and treatment.
Yep.
There's a parent who do not know, watching us out there, who doesn't know how to diagnose and where to seek help.
Yep.
How can you help them?
So for this answer, I will answer both as a pharmacist and as a caregiver, because I have been that parent. And I want to say, when it comes to things like seizures, the first time it happens, there's a lot of fear. There's a lot of not knowing. But what I'd say is, if your child experiences a convulsion, head out to your nearest health facility. As my colleague has mentioned, down to the basic levels, those facilities will be able to refer you if necessary. So it's not something to be feared. There is treatment out there. And this is something that we also want to highlight, that up to 80% in some places of people living with epilepsy are not accessing the treatment, not because the medication doesn't exist, but because of misconceptions, because of lack of awareness. So should your child have this kind of a condition, please do seek help. Right down from the basic levels and higher up in the different strata of hospitals, there are treatment options available for your child.
And when it comes to you know, parents taking their children to the hospital, they have so many questions. Is this hereditary? Is it something that maybe happened when the mother was maybe pregnant? Maybe you can demystify these questions.
Right. Epilepsy has different causes. And you are right. There are those epilepsies that are genetically linked. So, you know, generation after generation, you might find that certain members of the family are experiencing epilepsy. But there are what we call idiopathic, which is epilepsy that does not have a specific cause. So, and remember, epilepsy can happen at any age. It can happen to a newborn, it can happen to a baby, it can happen to the old. So, a neurologist once told me, if you have a brain, you can have a seizure. So not all types have a cause, but there are those that happen after maybe, for instance, brain injury. So again, seeking help, speaking to your doctors, exploring what has happened, they would be able to then advise you, this epilepsy has happened because of an infection. It has happened because of hereditary reasons. It has happened because of trauma, or it has just happened. But the point we want to emphasize is there is treatment and there is hope, and you can live a full life even with epilepsy.
We'll be talking about more in regards to that. Does it maybe as you grow old, just like asthma, as you grow old, does things become better? But allow me to engage Otieno in regards to our healthcare systems. Are they well equipped to handle epilepsy in the country, and especially when it comes to mashinani, you know?
Yeah, the biggest challenge with the health system in managing epilepsy is that most of the time you'll find that epilepsy is believed to be able to be managed only in the upper levels of the healthcare system. We are forgetting that epilepsy can easily and comfortably be managed within the primary healthcare level once they are well equipped and the medications are provided. We have situations where initially there were no medications completely. Even if a person went to a health facility, he was either sent back because even the practitioner at the facility believes on the myths and the misconceptions. But after much effort, now we have a situation where patients are retained within the facilities they go to first. They are treated and they are managed. We are minimizing the referral sequence of management of epilepsy. And ideally, we are looking at every county being able to manage epilepsy at the lowest cost possible. We started with Nairobi, where at the moment we are having approximately 29 health facilities giving medications for free.
In Nairobi,
which was not there initially, but now it's happening. So the advocacy is taking shape and we are seeing results. So we are hoping that other counties will pick up and the management of epilepsy will be available at the lowest health facility possible. So that is our whole game plan.
Yeah, I will still pose the same question as Otieno in regards to our capacity to handle this, and especially when it comes to, he's talked about 29, which is very encourageable, 29 health centers in Nairobi alone. I'm also looking at the cost itself, and from what you've done in Neuro-Rich Africa, because there's a gap that you're plugging.
Yes.
How are we doing in regards to the treatment and management when it comes to our health facilities?
Well, I think there's a lot to be done. And again, as you rightly said, there's a gap that we identified. So Nicholas and the team at Kawe and other organizations are really working hard in terms of providing this medication, affordable and even for free, as he's mentioned. But what Neuro-Reach specifically targets is the gap between the diagnosis, the prescription, and when you get home. So where we focus is providing support to the families between that diagnosis and when you're at home, because that's where the support is thinnest. So once you've gotten your prescription and you've headed home, you still have a lot of medication management in the house, seizure management in the house, the stigma, the worries about school. That is where we provide that support to the individuals and the families. So as more and more awareness comes into our media and through various other channels, we are able to meet that treatment gap, but we also need a lot of support in terms of how are these families coping with this same medication that you're giving them? Are they continuously taking this medication as prescribed? How are they handling the stigma at home and in the schools? Is the school agreeing to give this medication to the child whilst they're at school? So that's why we have to look at this holistically. So not only from the diagnosis and treatment, but all the way to the home. Yeah.
Otieno, take us through the management of epilepsy, especially for someone who has a patient at home. What are some of the do's and don'ts? And what are some of the things that many people don't understand or don't even know that they should be knowing?
Yeah, so basically, when someone has a seizure, first of all, there is that belief of where it came from. Most people still believe that it's as a result of witchcraft. Most people still believe that it's a curse. And most people still believe that it's as a result of possession by demons. And when they have these beliefs, the next point of action will be, if it is a curse, I'll take to a witch doctor. If it is a demon possession, I'll take them where they will be prayed for. Yep. Now, what this does to the whole system is that these patients will not come to health facilities, because they don't believe that it's a medical condition. Once they believe that it's not a medical condition, they'll do away with the hospital aspect of it. And that leads to the 80% treatment gap that we have. Only 20% of persons with epilepsy are coming to the facility. So there's a...
That leaves 80%?
Yes. We are only seeing 20% of persons with epilepsy within health facilities. 80% are still out there. Yeah. Again, we have a belief of epilepsy being contagious. That is why when a person has a seizure, the first reaction of persons around is usually to run away. They run away because they believe that if they touch this person, they'll get the seizure. Some people will not even share utensils with a person with epilepsy because they believe that they will contract the disease. Women with epilepsy are having challenges on situations where they need to get married. No one will accept to get married to a woman with epilepsy because they believe that all epilepsy is inherited. Not all epilepsy is inherited. So you will not have children who have epilepsy because you have epilepsy. As she said, most of the epilepsy we are managing is idiopathic. We don't know where it came from. And not everyone with epilepsy was born with epilepsy. So we always say that anything that can affect you can give you epilepsy. And most of the persons we are having getting epilepsy are getting it when they're adults. So a very small percentage is getting it when they're little. There's also another practice that happens where when a person has a seizure, you put a spoon in their mouth. It's a common factor that happens.
Yes.
What should be done is that you should not put anything when a person has a seizure. You should not put anything in their mouth. One, when you're putting that spoon in their mouth, you are forcing the spoon into their mouth. The first risk is you can break the jaw. The second risk is you can break the teeth. The third risk is you're introducing the infection to a tongue that has already been bitten. We have the injuries that will be there. By the time you even look for that spoon, the tongue biting that you're trying to prevent has already happened. So we usually insist don't put anything in their mouth. If they happen to have injuries within their tongue, just manage it, the normal wound management, or if it's severe, you take it to a health facility. You've never met someone who has no tongue because he bit his tongue and it's no longer there. So the tongue injury is usually an assumption that they will either bite their tongue or they will swallow their tongue. They can't. So you don't put anything within their mouth. Take them to health facilities. They get treatment. It's not contagious. So allow persons with epilepsy to live their life just like any other person within the community without restricting them. We have situations where persons with epilepsy are having challenges in schools. They are chased from schools because some of them believe that these people are demon possessed. So when a person has a seizure in a school, the school is forced to write a letter not allowing the patient in that institution. Patients with epilepsy are allowed to be in normal schools, just like any other person, unless they have other comorbidities. So they are supposed to be in normal schools, not special schools. We also have challenges in workplaces where persons with epilepsy are not getting employment. Once they declare that they have epilepsy, they don't get employed because of the assumptions and the myths that are there with epilepsy. These persons are very productive, by the way. There was a case study on return on investment on mental conditions, and epilepsy came up as one of the conditions that have a very good return on investment. In every 1 shilling you invest in Kenya on a person with epilepsy, on the management of a person with epilepsy, you have a return of 5.5 shillings. So that is a good return. So invest on them. Don't look at that investment as expenditure. Look at that investment as something that will be productive in future. Because once you manage their seizure, they'll be able to pay taxes. They'll be able to perform their duties just like any other person. We have doctors who have epilepsy. We have lawyers who have epilepsy. We have industrialists who have epilepsy. And they are doing their work so well. Until they tell you that I have epilepsy, you will not know. So these are people who are able to live their life fully just like any other person if given a chance.
Yes. Doc, allow me to go to the basics. When I joined school back in the mid-80s, we had these issues in school and we used to run away. And to be very honest, back then we thought maybe it's some sort of a demon. Because everyone would run away. But you have come up with a way that it can make it a little bit easier. This is what I'm talking about. This is one of the books that Doc has written, The Day the Purple Kite Flew. It's more or less, maybe you can tell us why you decided to venture into book writing. My Friend Amani, by Phyllis Kimani. We also have Siku Kishada Cha Zambarau Kilipopaa. It's an interesting one. The Siku Kishada Cha Zambarau Kilipopaa. Why did you think maybe if you put this message into these books, it's going to change the way we look at epilepsy in the country?
Right. So mine is a personal story. As I mentioned, I'm not only a pharmacist, but I'm also a caregiver. So the story behind the book started with my own daughter. So when she started experiencing seizures, and her siblings started asking questions, what is happening to her? Is she going to be okay? I went on to Amazon and I looked and looked for a book that could explain it to her siblings and herself in a simple way, you know, that a child can understand. And I got the book. But whilst I was buying the book, I asked myself, what about that person in Wajir who doesn't have access to Amazon? What about that person deep in Kwale who's having this child having a seizure and doesn't even know that there's something like a book for children that can explain it to herself and her child about what's happening? So that's where the idea of writing a book actually started, through my own experience. So the books I have authored are in English, Kiswahili, and Shona, because what I'm trying to do is not only specific to Kenya. If anything, when we look at the Kenyan context, we're actually doing far better than our African neighbors. So as Nicholas mentioned, in Kenya we have about 30 practicing neurologists. In other countries, you have maybe 1 if you're lucky. So epilepsy is something that we need to tackle, the stigma behind it, should I say, from Kenya and beyond. So what I've done with the books is, as Nicholas has mentioned, the first aid, very simple steps, and the books have been looked at and given the stamp of approval by neurologists here in Nairobi, leading pediatric neurologists. And what we've done is we have reduced the first aid steps to 4 simple steps. Number 1, safe. Keep the person safe during a seizure. Number 2, stay with the person. The idea of when a person has a seizure, run away, no, stay by them. Nothing will happen to you, it's not contagious. Number 3, place them on their side. So when they're convulsing, sometimes you have a bit of vomit or some aspiration. So when you place them on their side, they're able to breathe better because that liquid can just flow safely. And then the 4th one is Saidia. If the seizure lasts more than 5 minutes, go to your nearest health facility. Because obviously when a seizure lasts too long, it can be dangerous to the patient. So by making it as simple as possible for children, for their teachers, for their parents, we are able to spread the message of first aid and awareness, inclusion and friendship at a very basic level. Yeah.
Nick, I'm looking at the intersection of epilepsy and mental disorders. You will find that many people who suffer from epilepsy might also have other medical conditions, either because of isolation, either because of the stigma involved. Where do we pick it from there? And do we have situations where you found that people with epilepsy are also having mental conditions, and how are you able to help them?
Yeah, so first, there is always this confusion about epilepsy being a mental condition.
Yes.
Epilepsy in itself is a neurological condition. It's not a mental condition. But persons with epilepsy might experience stigma within the community. They get isolated, they don't get jobs, they get chased out of schools. That affects their mental capacity. They might get into depression, they might get into situations where they are not mentally okay. Now, when this happens, you will find that the assumption is all these people are dependent. They cannot be independent. They have to be helped to do whatever they want to do. So we first make sure that the awareness is there, so that they don't experience the stigma within the community, because that exclusion will lead them to first personal stigma. They will not accept themselves as persons with disability. So once you mention epilepsy, you will have an issue. So one, you will allow them to accept their condition as a medical condition. Then you get to the interpersonal stigma, where now the family members are stigmatizing them, in that they are overprotective. They don't want these patients to go out there and do things. They will find that persons with epilepsy are locked somewhere, because the assumption is when the community knows that we have a person with epilepsy, we will be excluded. So when that happens, this also affects these persons with epilepsy mentally. Then we have the community now stigmatizing these people, the angle of schooling and the workplaces. Now, when this happens, these people are not able to fend for themselves. This also leads to other mental conditions. Then we have seizures that are not controlled properly. When you don't manage seizures properly, it will lead to complications. So most people that will come with comorbidities, like there's this assumption that persons with epilepsy are mad. They are not mad people, they are just normal people. But you'll find that the seizure is not managed properly, and it leads to those complications. So in normal circumstances, it is just a neurological condition, and it's not a mental condition. But it can lead to mental conditions if not managed properly. Consider that most of persons with epilepsy will also not. They will come with epilepsy, but some of them will come with comorbidities. Comorbidities means that a person has epilepsy and he has cerebral palsy, has epilepsy, he has autism, has epilepsy, has Down syndrome. So we are approaching this angle of epilepsy management with a holistic approach, whereby we are doing the intersectoral management of epilepsy. Different sectors are involved. The mental sector is involved, the neurological sector is involved, and we are using a plan known as the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. So it is a 10-year plan that was authorized by the WHO, and it started from 2022 to 2031. So that is a 10-year plan, and we are looking forward to making sure that we achieve the expected plans and goals for the plan to work. So basically, we are not approaching epilepsy in itself. We are approaching epilepsy with other neurological condition and with the mental aspect of management, because it comes as a whole package.
Doc, why are many Kenyans diagnosis comes late, and what happens if somebody is on the medication either because of finances or because of maybe the location abruptly stops the medication? What happens?
So to answer your first question, why does it take so long for people to actually be on the medication? It's, as Nicholas has mentioned, it's the stigma. So we always say in Africa, which carries 80% of the world's should I say, Africa and other low and middle income countries carry 80% of the epilepsy burden globally.
Why is that? That's a very huge
It is
number.
quite huge. And you know, globally we have 50 million people who are suffering from epilepsy. And out of that, 80% are in low and middle income countries. Now, what we say is, out of those, the people who are coming to the facilities are 20%. Yeah, so there's the 80% that are still not coming. So the question is why? Again, back to the stigma, back to the distance. So if there's some countries, as I mentioned, who only have one neurologist, and when the care is concentrated to the referral hospitals, you can understand that the millions of people, you know, at the grassroots level will not have access to this care. So what we then say is, if we tackle the stigma, if we tackle the distance, whereby we're bringing care closer to the families, not leaving them into the referral institutions, then that will kind of, you know, reduce that gap. On the second question, you asked what happens if someone starts the medication and then abruptly stops them. It can lead to seizures, and sometimes it can lead to worsening of the seizures. So that is why it is very important. There's a way in which the medication is, as we call it, tapered up. So you don't start at a maximum dose. You start slow, and my colleague Nicholas and his team would then build you up to the required dose. And similarly, when it's time for you to stop this medication, the colleagues will taper you down. So you do not ever just stop abruptly. So there's a way and there's a science behind how to start them and how to stop them. And this should be done through, you know, trained professionals.
You're also a caregiver, and to many people, caregivers are the first line of defense. They are the first doctors. You're also a doctor, which actually enhances that. What are some of the do's and don'ts that you can advise somebody who is taking care of somebody who is epileptic, or somebody who's watching us and is epileptic? What are some of the do's and the don'ts?
So what I'd say as the do's, do take your medication as prescribed. Do visit your healthcare provider as recommended. If you're on a monthly clinic, attend your clinics. If for those who are more stable, you can be given a clinic every 3 months, every 6 months, attend your clinics as recommended. Do make sure that you have sufficient rest. So as an epileptic, sleep is very important, and rest is very important. Those are some of the things that can be triggers. If you're not well rested, alcohol is one of them as well. They can actually cause or worsen your seizures. So drinking in moderation, and there are those who may have to not drink at all. So following those instructions as per what the doctors recommend is one of my strongest do's. The ones I'd say don't are, as my colleague mentioned, don't put anything in the mouth. Don't, you know, again, in different cultures, especially in Africa, we have some communities that throw hot water on a person who is convulsing. Don't do those kind of things. They don't help. So, again, let's stick to the science. Let's stick to the facts. What epilepsy has suffered most from is the myths that have had thousands of years of head start. Now, in 2026, we have the facts, we have the science. So let's now spread the gospel of the truth. You know, this is a condition, this is what you do, and this is what you don't do.
Otieno, I'm looking at the gaps in the Kenya's epilepsy care systems. Being in the field for a number of years, what have you been able to deduce? Because the one thing that I got is that we have at least 29 facilities that can manage that here in Nairobi alone. But if you decide to talk about Mandera, then the numbers come down.
Yes.
That is one of the gaps that I've also identified. What are some of the gaps you've been able to identify?
So the first gap is usually the information gap. Information gap, people are not informed that epilepsy is a medical condition. So we handle that by communicating to the community, engaging the community health promoters, and engaging the elders within the community and the security system. We even involve the chiefs. So once the awareness aspect is done, we look at the treatment gap. The treatment gap now entails making sure that these health facilities are well equipped. Well equipped means that the personnel there are able to manage epilepsy. Once they are able to manage epilepsy, are they provided with the required medication? I might be able to manage epilepsy, but I don't have the medication in the facility. So we also ensure that the medications and the needs within the facilities are catered for. And we do this by approaching the health committee within the county assembly, because budgets are approved within the health committee. And most of the time you'll find that if epilepsy was budgeted for, and the person who is supposed to approve this budget is not aware of epilepsy as a medical condition, the funds will be diverted to other conditions that are deemed more important. So we also go to the county health committees to ensure that they understand that epilepsy is a medical condition with the help of the county health management team, so that these budgets, once they are written by the health team within the facility, the county assembly health committee understands that epilepsy is a treatable medical condition, so that the budgets that have been written within the facilities are approved, so that these facilities are given the required medications and the required equipments that they need to make sure that this is available. So once we do that, we will be able to make sure that epilepsy is managed comfortably at the primary health care level. Because the biggest challenge is the expense of referral and taking patients to the referral centers, where the population is so high, they'll be booked for long before they get the medication. The consultation is expensive, and they need transport to go to those places.
Right.
So you are making it easier for that person to access medication where he is. And once we do that, things will be easier.
All right. As we wrap up, Doc, this is good. This is good. And as NeuroReach Africa, you're trying to reach every corner that you can, and especially when we begin small, you know, our kids, then they become teenagers. We have a better understanding of this. What more are you doing as NeuroReach, and what more needs to be done in Africa to change this perception? 80% of the world's burden is a big number.
Yes, there is a big task ahead of us, but we are ready and we are working towards closing this gap. So, as I said, we are working on research as well. So, research into digital tools that patients and families can access through the comfort of their homes on their phones. So please do watch out for this space. Yes. We will be coming back with some more on that. But this book, I want it to reach every corner of the country, every corner of Africa.
Where can people get these books?
So as of the end of this week, we will start with Ava Pharmacy. This is a pharmacy that is based in Karen, in Mombasa, and in Westlands. So we're starting there, and also the Karen Pediatric Clinic. So that is a pediatrician who's based in Karen. And there'll be more locations announced through our social media pages. So please do follow us on NeuroReach Africa. We are on Instagram, TikTok, Facebook. Yes, so plenty to come.
Thank you. That has been Dr. Phyllis Kimani, who is a pharmacist, caregiver, and also a NeuroReach Africa founder, just trying to create more awareness. And as you can see, she's doing a fantastic job in ensuring that all Kenyans, and especially when we begin with our kids, trust me, we will change the perception, we will change the myths, we will change all that. Thank you so much indeed for joining us. And just next to her, we have Nicholas Otieno, who is a clinical epileptologist and also a member of KAWE. Many thanks indeed for joining us and for your insights. If you would want more discussion in that, kindly reach us out. If you're somebody who needs help, kindly reach us out on our social media spaces, and we will be able to not only connect you, you'll be able to get help. That's where we put a cap on KBC News Check this Tuesday morning.